by Dr. Glenn Butt.
Good morning.
Good morning. Thank you so much for your patience while we got our technical issues handled. Would you like to go ahead and tell the executive committee what about your request?
Yes, I'm a retired physician. I'm 72 years old, and I do about 12 hours a week at Manna Ministries volunteering. Manna Ministries Medical Services. We see patients for free, and they have grants so they can get blood work on them. And we work with pharmaceutical companies so they can get a lot of their medications free. My wife is a full-time teacher of licensed practical nursing at Pearl River Community College, but she is a nurse practitioner and she wishes to continue doing that on a limited basis. So she volunteers for 4 hours a week, and I'm supposed to supervise her, but I do not meet the 20-hour a week requirements. Since neither of us is being paid, I think it's, and this is a big service to the community, I think this is a reasonable request to let us waive the 20-hour requirement.
And so, Dr. Butt, just for the benefit of those who did not have the documents that you provided to us, can you tell us a little bit about your background?
Yes, I'm a internist. I practiced for 20 years in the Pearl River, Louisiana community, and retired about a year and 3 quarters ago.
And so what exactly is the extent of the practice that you do at for Manna Ministries?
Well, they book patients for me just like a regular clinic, and I've see people who are oftentimes very neglected because they have no insurance. Many of them have gone for years without their medications, and some of them are sick, and some of them are not sick at all because they're coming in because it's free. So it's a very mixed bag, but these are people who would fall through the cracks.
And what training has your wife had with respect to her nurse practitioner? Does she have a particular area of focus?
She's in family practice. And she got her training at the University of Southern Alabama.
Hey, I'm Tom Joyner. When you retired, did you go to work immediately for the free clinic?
What's the 320?
Was there a gap in practice?
Only probably about 2 or 3 months.
2 or 3 months. Okay, I'm good.
Yeah, any questions?
Dr. Butts, I'm Ken Lippincott, particularly, and I was just wondering, does your wife have other collaborating preceptors besides you?
Well, no. Well, I guess there's another Dr. Bolton, DL Bolton, and he also only works about 8 hours a week. He's 88, but he's the other doctor there. And then I don't know if she's I'm the one who goes through her charts and make sure they're good.
Okay, so
he's not a formal collaborator that I know of.
So does she have a backup collaborator?
Yeah, we can have Dr. Bolton do that. We haven't done that formally, but we can.
Thank you.
Any other questions? So
I'll make a move that we approve the request.
I second the motion.
okay, so it's been moved and properly seconded that the request be approved. All in favor? Aye. So it's unanimous. So Dr. Butt, your request has been approved. Thank you so much for your time and for your patience.
Thank you all so much.
Excellent.
All right. Bye-bye.
Moving on the agenda, we'll have the presentation by, I believe it's Dr. Kreitz Backer.
Yeah, Kreitzbacher. Yes. Hi. Hi, good morning. So I am a urologist. I'm here with Dr. Kara Doherty. She's a nurse practitioner. We are asking for a collaborative approval. We both work for a telehealth company, both licensed in all 50 states and DC. We do provide services to Mississippi, obviously. So we are asking, because she is in Missouri, I am splitting time between Portland, Oregon, and Arizona. We don't meet the criteria for the mileage limit. So we are asking for an exception to that, since we are exclusively telehealth with Willcrest Medical Group and Analyte Health, that we enter into a collaborative agreement, which we're already in with a couple of other states that we cover. We're in nearly daily contact by text message, by phone, by Zoom, by email. So it's not a problem for us to talk, because we've already established that precedent.
Let's see. So can you tell me a little bit about Ms. Doherty's her background and her training?
Mm-hmm. Yeah, family nurse practitioner. I mean, do you want me to answer that, or would you like Dr. Doherty to answer that?
She can answer it. That's fine.
Okay.
Hello, and thank y'all for meeting with us today. I am a family nurse practitioner. I have 28 years in healthcare, 22 of those as a family nurse practitioner. I have done everything from emergency medicine to bariatric medicine. Urgent care and ER typically are the background that I come from. And I have been exclusively in the telemedicine realm for the last 8 years, but that dates all the way back to the early 2000s in the emergency department, using telemedicine at that point as well. But well-rounded, but family is the focus. Predominant specialty at this juncture is telemedicine only, typically urgent care to the urology care that Dr. Bacher is speaking of.
And Dr. Bacher, as you just thinking about urology, I mean, it's a surgical subspecialty. So can you tell us a little bit about how you, what your practice is like, utilizing telehealth in a surgical specialty?
Yeah, so I'm not actually practicing surgery, obviously, by telehealth. The company that we are collaborating and that we contract with treat low risk issues such as sexually transmitted diseases, vaginal infections. We'll give advice on labs that come through, basically those low risk sorts of things that fall within the family medicine emergency room, but also urology realm.
And what kind of, so how do you test for, because you're mentioning like STIs and those kinds of things, do you use like home collection or patient collection kits?
No, they go, the patients order the labs, they log on to the website, they order the labs, they go to their local lab, they get their lab tests done. So what we're treating, we've already got lab results for.
Gotcha.
Your practice located? I'm Tom Jordan. Where's most of your practice located?
So we're both almost exclusively telemedicine, so we're nationwide.
I understand that, but you cover all of Mississippi. And somebody
Yep.
just comes in and says, I need a urology consult.
No, they log into the website, they order their labs, and they get treatment for STDs, UTIs, that sort of thing. So it covers all states nationwide.
How do they learn about you? How would I know to call you?
They don't call us specifically. It is through the company. It is through the website. We contract with the company and we just provide, the patients can schedule with whomever is on the schedule that day, whoever is working for that day.
Okay, what company is that?
It's Willcrest Medical Group and Analyte Health.
Okay.
Dr. Backer. My name's Ken Cleveland. I'm the executive director here at the board. So you said the patients can log in and order their own labs. I have to double check this, but I believe in the state of Mississippi, labs have to be ordered by a physician. So do you
Yes.
approve those, or does
We
somebody
do.
with authority approve those?
Yes, we approve those. If we are on the schedule working that day, we approve those labs when the requisition comes through.
Have you ever denied labs?
I haven't, simply because, patients think that they've been exposed to sexually transmitted diseases. So if they believe that they've been exposed, we certainly, just like any urgent care or emergency department, we will order those labs.
And I don't have the nurse practitioner's name in front of me, so I apologize for that. But in the state of Mississippi, and I'm not sure if this is true in all states or not, but nurse practitioners are not allowed to refer themselves as doctors in a clinical setting. Are y'all aware of that?
Yes.
I just heard you refer to her as doctor.
Yes. So all of that is ordered. That comes through the physicians. Yes. There are multiple physicians that work for the company. So there can be multiple physicians on for a day, but all of those labs come through the physicians to approve the order, just whatever physician is working that day.
I apologize. I changed subjects. I mean, the nurse practitioner in a clinical setting, which in this situation would be over telemedicine, is not allowed in the state of Mississippi to refer to herself as doctor. She has to make it very clear that she's a nurse practitioner.
If I may, I do not refer to myself as a doctor. Honestly, I use first name and explain that I am the nurse practitioner that will be treating them. I in no way ever represent myself in a way that could be misconstrued as being a physician, I believe is the whole process there. To me, it's a degree title, but I don't even utilize that in the clinical setting. I'm a first name basis and proud to be a nurse practitioner. So I represent as such. But I am very much aware of that. And quite honestly, since I use first name basis only across the nation, it doesn't impact me, but I'm very much aware of the ruling.
I just didn't want you to get yourself in trouble with board of nurses.
Absolutely. I agree.
Hey, this is Tom Joyner again. The labs that you're ordering seem to be labs that are very basic to family practitioners, internists, OBGYNs and such. And I think we got good coverage of that from Memphis all the way down to Biloxi. Where do you think you fit in this state?
Well, from my standpoint, we're specifically treating STDs and urinary tract infections. So, the patients most of them want to utilize the website, for ease and for privacy, because most of them honestly don't want to go. They don't want it announced that they've got sexually transmitted diseases. So it adds a layer of anonymity, such that it is, it's cash pay. So they can pay cash for their labs, and then they, get their labs done, and then they consult with us. We prescribe the antibiotics or antivirals, whatever it is that they may need. And then they just go to the pharmacy and pick those things up.
Okay, if you have a positive RPR or GC test, do you report that to the health department?
Yes, we have through the company, we have policies in place that yes, it is.
Any other questions of the executive committee?
I'm Dr. Ken Lippincott, and I just wanted to clarify the process. So a patient searches for, treatment for, STDs, and your company's, they find your company's website, and they contact the company, and then does the company cover all medical specialties?
No, it's just, we're just treating low-risk STDs and urinary tract infections. That's all we treat. We do not cover family medicine. We do not cover endocrinology, any of that sort of thing.
So, excuse me, the Chris and Analyte, they just treat STDs.
STDs, urinary tract infections, correct. That's all we do.
So, so the entire medical staff of Chris and Analyte are urologists?
No, no, I happen to be a urologist, but they can be family medicine, they can be emergency medicine, they can be OBGYN, they can be urology, specifically trained to treat those particular entities.
Okay, okay, I think I understand. Thank you for answering the question.
So is there any component of like sexual dysfunction or anything like that that you treat as part of your practice?
No,
No hormone replacement therapy.
no, it is exclusively STDs and urinary tract infections.
All right. Any other questions, gentlemen?
Nope.
You want to, so I'll entertain a motion, and if you want to go into executive session, we can do that as well.
I'm moving to go into executive session.
A second.
All right, so it's been moved and properly seconded that we close the meeting to determine whether to enter into executive session. All in favor?
Yeah.
Dr. Tom Joyner, Secretary of the Board, will read the decision from executive session.
Thank you. After a meeting in executive session, we have voted to deny the request.
Okay, thank you all for your time.
Thank you.
Thank you for coming. Okay. Our final item on our agenda for today is the appearance of Dr. Theodore Ted Feldman.
I'm here, present.
All right. Good morning, Dr. Feldman. I'm Michelle Owens, board president, and so we are just eager to hear about your request today.
Well, I'm eager to share it with you. Good morning, everyone.
Dr. Owens, if you wouldn't mind, my name is Brian Higgins. I'm an attorney. I represent Cadence. I was wondering if it would be okay if I led off with a little bit of an overview of our services and Dr. Feldman's request. Would that be all right with the board?
Would it be permissible if he just kind of says it in his own words and then you can kind of follow up? We would like to hear from the licensee if at all possible first.
Yeah, absolutely. I think an overview could answer some questions, but yes, we will proceed with just Dr. Feldman.
No, you can definitely follow up after him. Okay. Dr. Feldman.
Good morning, everyone. Shall I begin, Doc?
Please.
Okay, great. Well, I appreciate the opportunity to meet with the board today, consider our exception. I believe it's absolutely in the best interest of the patients and folks in the state of Mississippi. By background, Cadence is a remote physiologic monitoring company that I helped start in August of 2020. I've been a practicing board-certified cardiologist and internist in the state of Florida since 1983 for internal medicine, 1987 for cardiology. I was one of the fortunate ones who got in with a lifetime certification. So I'm very grateful for that, as I see my colleagues sort of struggling to keep up with the 10-year exemption. As a practicing cardiologist, I still practice 1 day a week in person, 1 day a week virtual within the Baptist Health System of South Florida, which is the largest not-for-profit health system in the Southeast United States, and have been a member in good standing of now an 11 hospital medical staff for the last 37 years. As a cardiologist, we are very much involved in the care of patients, both in hospital, in office, and now with remote patient monitoring technology, actually in the comfort of their home. We've been doing it for years with arrhythmia monitoring, and over the past 15 to 20 years now, chronic disease management around coronary artery disease, hypertension, hyperlipidemia, and congestive heart failure, using blood pressure cuffs, continuous or home blood glucose monitoring, regular scales, and pulse oximetry has allowed us to extend the care of patients from the clinic and the hospital into the home in a very effective way. In 2019, Medicare stood up CMS several codes which allowed us to move chronic care management using remote patient monitoring in combination with virtual care into the forefront for 4 particular diagnoses, which include congestive heart failure, hypertension, diabetes, where we have been focused at Cadence, and chronic obstructive lung disease, for which we have not actively embarked on a program. The notion, as someone who has been involved in population health and preventive cardiology for a large health system, I was often the one that was being asked to evaluate these remote patient monitoring platforms, which allowed patients to check on their blood pressure, their blood sugar, their weight, and share it with their practitioners in real time. And one of the limitations that I saw, quite frankly, was the inability to accumulate all of this data, and for the existing care team, meaning in a practice like ours with 35 cardiologists, looking at hundreds and hundreds of vital sign alerts around blood pressure or blood sugar. At the end of the day, we just did not have the bandwidth to be able to effectively utilize the data that we were acquiring in ways that would meaningfully change care. Towards that end, then we stood up the concept that remote patient monitoring could only move forward if we had a care delivery team, which would be able to use that data in conjunction with the patient's primary care physician or specialists like endocrinologists or cardiologists to help move along the care for congestive heart failure, hypertension, and diabetes. And we're all very familiar with the fact that the guidelines for care in these particular chronic care management has been well worked out by national guidelines, American Heart Association, American College of Cardiology, American Society of Hypertension, American Diabetes Association. So what we would be doing would be attaching a licensed care delivery team with very highly qualified nurse practitioners who have specialties within the areas of these chronic disease management areas, in association with health systems who would refer patients to our licensed NP platform with a technology platform, and would be able to use guideline-directed medical therapy in a way that we could advance and improve patient care. We are now operating since 2020, and we are now caring for over 10,000 patients. We're operating in 8 health systems, partners across 13 states. And as I said, we're providing care for over 10,000 patients. What I'm most proud of is that in this remote patient monitoring setting with an advanced nurse practitioner platform and very sophisticated technology to look at vital sign alerts and determine when and where people need to be evaluated either immediately or within the next 24 to 48 hours or subsequently, we've been able to significantly improve patient outcomes. We have reported on and presented at national meetings, the Heart Failure Society of America. We have 2 presentations at the American Heart Association upcoming, which include improved patient outcomes around a significant reduction in ED visits for people within 6 months of participation in the Cadence program, an 18% reduction. We've had a 5-time increase in the percentage of CHF patients who were able to get on all 4 pillars of guideline-directed medical therapy, which we know is associated with reduction in recurrent hospitalizations, improvement in outcome and survival. We've had a 55% increase in the percentage of hypertension patients with well-controlled blood pressure, and 43% of our type 2 diabetes patients achieve their blood glucose goal. We have been fortunate to partner with a group in Mississippi through Community Health Services, the Merit Health Madison Clinic in Canton, Mississippi, and I believe their medical director, Dr. Gregory Oden, is here with us today if you would like to hear from him. But we estimate that recent data has shown that about 15% of Mississippians have been diagnosed with diabetes, and as of 2021, nearly 1 million adult Mississippians, or 44%, have experienced high blood pressure. Well, we also know that rates of obesity in the Southeast United States and the 9 states, of which Mississippi is one of those 9, will have obesity rates fueling hypertension, diabetes, and congestive heart failure in the range of 50% by the year 2030. We also know that over the past decade, from 2011 to 2021, the prevalence of hypertension in Mississippi is increased by approximately 12%. So we feel that our remote patient monitoring system, partnering with clinics on the ground within the state of Mississippi, can help move the needle to improve patient outcomes for the patients of Mississippi. What we're specifically asking for then is in order to help partner with our Mississippi healthcare providers at Community Health Services, at Merit Health in Madison, we request I guess what would be an exemption for the, and here Brian can help me, but for the Mississippi rule, I believe it's Part 2630, Chapter 1, Rule 1.2, that requires a physician to practice within the state of Mississippi for 20 hours per week or 80 hours per month. I actively practice 20 hours per week and 80 hours per month in the state of Florida, and also the remaining 20 hours per week and 80 hours per month supervising our advanced practice nurses, which is, I might add, in the states that we're at, has worked quite well. We review NP and meet with NPs weekly on a group basis, discuss cases, have a very robust quality assurance program. We meet individually as medical directors to maintain our collaborative nurse practice agreements in the states we're practicing. Monthly, we review a large number of cases and as I've said, have an extremely robust quality assurance program. In my 35 plus years within the Baptist Health System, I've served in a variety of leadership roles, particularly focused around continued process improvement and quality assurance. So I've been able to lend that expertise to the Cadence QI program. I guess the last point that I would make is that there is another exemption to the in-state rule around mileage exemption. And in a very simplistic way, without being the lawyer in the room, we would ask an exemption around that. But we do believe that we have demonstrated the fact that this model works, that this model has worked in other states. We have a very robust program within the state of Alabama, one of your neighboring states, as well as Tennessee, Virginia, Wisconsin, Washington State, and a variety of others. So we know the model works. We've been extremely fortunate to show improvement in care delivery. Needless to say, our patients, when we look at Net Promoter Scores, are extraordinarily happy, as well as our providers, because we're able to extend care in a quality way for people with chronic diseases. And we also often know that these days, particularly in a post-COVID world, access to high-quality primary and specialty care is quite difficult. And we think that one of the roles that we're playing by improving access to these chronic diseases is the ability to move the needle. I'll just say in conclusion that Medicare has estimated that 70% of all outpatient visits for the Medicare population center around chronic care and chronic disease management, which we believe, as well as Medicare believes in funding this payment program, can be adequately done with virtual care and remote patient monitoring. So I present that case to you. I apologize for the length of my summary, but hopefully that gives you a better understanding of what we're asking for, the reasons why, and a true belief on the part of Cadence, as well as myself, that we can really help move the needle on improving the chronic care of patients within the state of Mississippi. So I thank you for your time, and I ask you for your indulgence of our request in this case.
At this time, we can go ahead and hear from Mr. Higgins.
Yes, thank you very much, Dr. Feldman. That was a great overview. Just a few different things I would add. Like Dr. Feldman said, we partner with health systems in order to offer this service. And the group that we will be offering this through in Mississippi is Merit Health Medical Group, and they're a part of Community Health Systems. We estimate that based on the 3 main chronic conditions we serve, we are going to be able to reach 9,000 Mississippians through this partnership alone. And so we want the board to consider, the impact that we will have on clinical outcomes. I'll also reinforce the fact that Dr. Feldman is a Mississippi licensed physician, and all of the APRNs that he will work with are are licensed APRNs in Mississippi. And he will supervise a maximum of up to 4 of them per company policy, which we instituted based on the fact that we know that that is the most conservative physician to nurse practitioner ratio across the United States. He will also meet on a weekly basis with each of the APRNs as a group and individually on a monthly basis to discuss their collaboration and patient case issues. He's also continuously available to the APRNs for consultation via telecommunication at any moment. And finally, in accordance with the board's Rule 1.8, he will also review 10% or 20 charts, whichever is fewer of patients seen by one of the 4 APRNs with which he collaborates on a monthly basis. So we've tried to structure this arrangement to meet as many of the board's requirements as possible, with the exception of the fact that he will not be practicing at least 20 hours a week in Mississippi, and he will also be further than 75 miles away from these patients. Happy to provide any more detail, and obviously we will answer any more questions you have.
Thank you. Dr. Feldman, with respect to the process, if you have escalation that is necessary based on your monitoring systems, how exactly would that be carried out in real time?
Sure. Great question. I mean, obviously, it's the technology platform around alerts, primarily related to blood pressure, in all fairness. I mean, we have red, yellow, green alerts in a similar way to a traffic sign. Red obviously being, something that needs to be dealt with emergently. Yellow is often and again, we are closely integrated with the EMRs. The biggest ones that we've integrated with are Epic, Cerner, and Athena, which represent a disproportionately large percentage of the EMR. So a yellow alert will be, if I see a hypertensive patient this week and let's say might have a follow-up in 3 to 6 months, if there's only yellow or green alerts, that will be in the chart when I see the patient next. And I can use that data to maybe make drug titrations up or down, or feel comfortable that we are in a good range. For the red alert, which I think is what you're referring to specifically, someone has an elevated blood pressure, they may be in our hypertension or heart failure program, and it's above what we have determined. And again, when I say we, the determinations are really made off of national guidelines in conjunction and discussion and agreement with our clinical partners for what would constitute a red alert. We have a protocol by which we personalize to the individual clinic contact with the patient and the healthcare provider, depending on the time of day. But for someone, let's just say, has a blood pressure of 200/120, we would ask them to repeat it in real time. If in fact it is, then we'll do a reach out around whether they're having any symptoms or not. Assuming that there is symptomatology, we will then reach out directly with the patient. That might require a hang up and call 911 and go directly to the emergency room. It might be a referral to urgent care. A lot of that, again, is going to be driven by how the clinic wants us and how they would react to a red alert in real time if they got it. So we're trying to work within our existing systems. If it would be a red alert during the day in which someone might be in clinic, we have clinical navigators in the clinic that we define that will make sure that they contact the care provider and get direct access from he or she as to how they might want to proceed. And thereby in real time, we've been able to, we had an example of someone who had a very, very low blood pressure and otherwise felt fine. And in repeating it was wound up to be low, and it wound up to be an elderly patient who wound up being septic from a urinary tract infection. And by the identification of a red alert hypotensive blood pressure, we were able to get the patient to the emergency room and on IV antibiotics in a way that we think ultimately impacted on a more favorable outcome. So it's the red alerts that we are most focused on. Most of the red alerts are around blood pressure. We will really have a hypoglycemic or a hyperglycemic red alert. And again, we are dealing with the emergency circumstance in the most appropriate manner that any healthcare professional would, personalizing it to the needs and specificities and desires in which our clinic partners want us to respond.
And how do you integrate your practice with the health systems that you collaborate with? Because it seems like if they are a part of your program, then there is a component or an element of their care that you are also providing. So for a person who may have a primary care doctor who is in this health system, how exactly does Cadence fit into that?
Sure. Good, great question. And that's sort of the basic of the way we interact. Just think of us as the partner down the hall in your clinic. You're the primary care doctor. We will go into the medical records and identify patients in your panel with your permission, and the health systems provide us and the individual physicians permission to see the patients that they may be seeing that week who might be eligible for the remote patient monitoring program. We then leave it up to the primary care physician primarily, or the specialist where appropriate, to say, yeah, you know what, Mrs. Jones would be a great patient for your remote patient monitoring clinic. We have had enrollers both within clinics as well as now virtual enrollers who then introduce the program to the patient, saying, Mrs. Jones, I was referred by Dr. Feldman. We have this remote patient monitoring program, which we know can help better take care of your hypertension, your diabetes, your congestive heart failure. We are working in conjunction with Dr. So-and-so at the health clinic, and we basically serve as the NP that you would like to hire to take care of these patients to help increase access so we can move the needle on guideline-directed medical therapy in ways which will improve your outcome. And thereby, we're just an extension of your primary care practice, and we are working under very specific orders and direction of your primary care physician to check your blood pressure, check your blood sugar, and make sure you're on all the appropriate medicines with all the appropriate clinical follow-up.
Any questions?
Yeah, this is Tom Joyner. I'm a family practice doctor, about 40 years of experience. So you're telling me that your cardiac monitoring is real time?
We're monitoring blood pressure in order to meet the criteria for Medicare's ability, our ability on behalf of our client to bill Medicare. Patients have to monitor their vital signs, their weight, their blood pressure, at least 16 out of 30 days. So it is in real time, but it's not 24/7, 365 in real time. They may check in with a morning blood pressure, an afternoon blood pressure, a postprandial blood sugar. So that's the real time, but it's not continuous RPM. Now, if the patient becomes symptomatic, something is not right, they may then ultimately check that vital sign that may generate an alert on our alert board, which then may trigger a reach out on the part of our team or the primary care team.
Blood pressure, blood sugar. I'm talking about cardiac monitoring, rhythm, that sort of thing.
We are not monitoring cardiac rhythms as part of this program. There are many other remote patient monitoring programs that monitor people's arrhythmia is in real time. That is not the focus of Cadence. Our specific focus is around blood pressure monitors, blood sugar monitors, and weight scales for the specific management of congestive heart failure, whether it be heart failure with reduced ejection fraction or heart failure with preserved ejection fraction as one diagnosis, hypertension is a second diagnosis, and diabetes is a third diagnosis. We are not in the arrhythmia monitoring world, and at present have no intention to do that.
All right, the University of Mississippi has a robust telemedicine system, and they also do remote cardiac monitoring. Why would I choose you, an out-of-state physician, over the university? And there are several other entities that monitor, Baptist, St. Dominic's, several other entities that have hospitals that are located where the patients are throughout the state.
I mean, there are, I'm sure, a lot of answers to that, and that's obviously a very complicated question. Certainly, any health system is free to work with and partner with whatever group will meet their needs. I can only, and I don't want to speak for CHS and Merit, but there are competitive issues within the marketplace. We've had and have actually stood up programs, sir, for large, very prestigious academic health systems like the University of Mississippi that have been ineffective in their ability to move the needle on improved patient outcomes with RPM because they don't have that robust either monitoring platform or, more relevant, a large enough clinical team to be able to operate this in real time. So, we have had a lot of health systems, like I said, that have tried and failed and come to us. And it's really our ability to stand up a very sophisticated, very experienced clinical team that's licensed within the state that can add on as needed without having to have these academic health systems go out and hire 10, 20, 30 NPs and then find out that the program doesn't work and then figure out what to do with them. The nice part about a relationship with Cadence is it's very flexible and very transparent, and you can move us in and add or take us out and reduce without carrying the financial and clinical burden that many programs have tried to do on their own and have failed. So, but in terms of other issues around competition in the marketplace and other things, I'll leave that to our CHS and Merit Health team to answer.
Yeah, I'd just say, just to be clear, we would be happy to partner with any Mississippi-based healthcare providers. Our point of entry into Mississippi is through our partnership with Community Health Systems and Merit. So it will only be their physicians who will be able to order these services for their patients right now.
And just for the sake of clarity, since it did come up, marketplace competition and practice is not really within the purview of this body. So that is not really anything that is an important factor in consideration or our decision making. Just for
And I mean, I certainly understand that. It was just a difficult question for me to answer because I'm not the, providers within the state. So I certainly appreciate and respect your opinion on that.
Dr. Feldman, my name's Ken Cleveland. I'm the executive director here at the medical board. If you are working in conjunction with Merit Health and you're monitoring a patient with diabetes and you come across a new diagnosis of hypertension, do you refer that patient back to the physician at Merit Health, or did you start treating the hypertension?
No, we will absolutely 100% under those circumstances make the diagnosis, discuss with the patient, and refer them back to their primary care provider. We have very, very narrow windows in which we are able to operate contractually around very specific diagnoses and very specific care plans. That's not to say that we won't function as a responsible healthcare provider where patients present us with other information, as in the example that you discuss, a new diagnosis of hypertension. But that will absolutely be referred back to the practice for ongoing continued care, and not something that we will take on ourselves other than the navigation back to the appropriate referring healthcare provider.
So y'all provide consulting activities only, really. You do not do any actual assessment plan primary care.
Well, let me just clarify. We obviously providing consultative services, but within the narrow scope of the 3 chronic diseases that we've discussed, we will have permission and direct guidance from our practitioners that within the constraints of the guidelines, we may be able, for example, someone just discharged with congestive heart failure may leave the hospital on 2 of the 4 medicines that are the pillars of guideline-directed medical therapy. The purpose of the program then will be for the practitioner to directly refer to us the ability to add the other 2 pillars of guideline-directed medical therapy over a finite period of time post-hospitalization, which we know is associated with improved outcomes. So there are very limited but specific indications in which our nurse practitioner team will actually be up titrating, down titrating specific medicines related to guideline-directed medical therapy for CHF, hypertension, or diabetes. We do have other practitioners who fall under what we call monitor only. So they only want us to monitor and make recommendations. But in all cases, all of the orders that we may even write or suggest are countered by our primary care or specialty referrals. So at the end of the day, no orders are getting done unless they're ultimately approved, but we will move the order along to help expedite the improved care that's associated with improved outcomes.
Yes, and anything that we do recommend from a clinical standpoint is agreed upon with the health system in advance. We have robust clinical protocols for each of our disease states that talk about the medications we use and how they will be used in the labs that we recommend be ordered to their provider way in advance of ever launching the program. And so they're well aware of the recommendations they're getting from us. And then, like Dr. Feldman said, the ordering physician is the one who actually has to approve any of those actions before they actually go into place for the patient.
All right, one last question from me. Who owns the patient chart when y'all consult with a patient? Does Dr. Feldman own the chart? Does Cadence own the chart? Or does Merit Health own the chart?
Brian, do you want to answer that? I know I certainly don't know.
Absolutely. Absolutely. So no, it's ultimately Merit Health. So these services by Medicare are we're ultimately billing all of the services under the Merit Health physician to Medicare. And so they're the one who has the responsibility to maintain the EMR. All the data that we collect and from the patient through our devices and also through our clinical encounters with the patient and any alerts that they may trigger, those are all captured in our own Cadence platform. But we have a integration through technology with each of the EMRs of the systems that we work with. And so we push all that data directly into Epic, for example, or Athena. So it populates and shows up right for the primary care physician. When they see their patients, they can click on a tab and they can see exactly how the patient has progressed through monitoring with us over time, and all the notes are available to them. So everything that we do ultimately ends up in Merit's EMR, for example, and they will be that will be the EMR of record, if you will.
Yeah, I just had a short question. Dr. Feldman, how many nurse practitioners do you supervise?
That's a very good question. I'm and Brian, you may be able to help me. I know where we have 4 within the state of North Carolina that I supervise. I want to say between 6 and 8 nurse practitioners I'm supervising now in a variety of different states.
Yeah, that's right. We also have another physician on staff who provides similar services for us to reach the other states that we mentioned previously.
And I noticed your 4 nurse practitioners all have New York addresses. Is that the corporate address, or where they physically located?
Yes, that's the corporate address that's listed there. Our nurse practitioners are all licensed in Mississippi, but they do live in surrounding states as well. This is a model that we've deployed in Alabama. And so we've modeled the same structure that we present here to the board for consideration.
So Dr. Feldman, when you meet with the nurse practitioners, you're meeting electronically, is that correct?
Yeah, that is correct. We have the medical record that we can both access to review particular charts, and we're meeting virtually on a weekly basis as groups, presenting grand rounds, interesting cases, and then we have a monthly QA CPI meeting, and then I meet individually with all of the NPs that I supervise directly to go over any issues, any questions, any interesting cases, or any QA issues. Fortunately, I will share with you, sir, that the level and the quality of our NP team has been so outstanding that the need for even more active intervention and supervision has not been necessary. But our program is certainly set up that we can deal with any issues that arise. And obviously, we're managing a variety of fairly sick and chronically ill patients over a wide platform, but the model seems to work. And again, we're not working alone. We're working in very close conjunction with the patient's primary care and specialty teams.
Dr. Feldman, really quickly, I'm just trying to make sure that I have a full understanding of the scope of your request. In the documents that were submitted to the board, there is a request for an exemption to Part 2630 Rule 1.8, which speaks to the APRN MD chart review. Mr. Higgins stated that you would comply with that, but it is listed as a request as an exception in the documents that are presented. So can one of you clarify whether or not your request is for an exemption to 1.8, or if it is in fact that you will comply and that is no longer an element of the request for exemption?
Yes, I will clarify. That is no longer a request for exemption. We will be complying with that rule. So thank you for the question. I also wanted to mention that Dr. Gregory Oden is on the line right now as well. He's the Chief Medical Officer of Merit Health Medical here in Mississippi. So if there are any other questions that you might want to direct to him, he is available as well.
Has Merit worked with this company before, or is this a new program?
I think they're asking so that they can partner if they want to partner.
So, okay, so this is a proposed, okay.
Correct. Yes, we have. Merit is a part of Community Health Systems, a large healthcare provider in the Southeast, obviously. We've run very successful partnerships in other states with medical groups that are a part of Community Health Systems, but this would be our entry point into the state of Mississippi.
Thank you.
Anything further, gentlemen? At this point, I'll entertain a motion.
I move to go into executive session.
Second promotion for those executive.
Well, we got to
So-
do this one first.
So it's been moved and properly seconded to close the meeting to consider whether to go into executive session. All in-
So it's me.
all in favor?
All right. Now, I need to go into executive session.
We'll do that when we get into.
Okay, so that's when you start writing email information.
We are now out of executive session, and Dr. Tom Joyner, Secretary, will read the decision of the executive committee.
The executive committee voted to approve the request with exemptions limited to the specific partnership and collaboration with Merit Health as presented to the board today.
Thank you so much, sir. We greatly appreciate it.
Thank you.
Thank you.
Thank you all for your time.
Okay, you all have a nice day.
Have a nice day. Thank you.
All right. So as I mentioned earlier, our last presenter fell off the agenda. So that concludes our agenda for the executive committee meeting. Can I get a motion to adjourn, please?
So moved.
Okay.
Thank you.
What do I do? I click on this. It's the board. Left.